I would like to do a module on the pathophysiology of congenital adrenal hyperplasia because I wanted you to get a good understanding of what is actually going on in these individuals when they have this condition. In looking at hormones, we know that we have a category of hormones which are called steroid hormones, and all of the steroid hormones are derived from cholesterol. And if we look at where they're released from, they're released from the reproductive organs. We have our androgens by the testes in the males, estrogens and progestins by the ovaries in the females, and the cortex of the adrenal glands, the corticosteroids, and then the kidneys, the calcitriol. What I want to be looking at is those corticosteroids, which are produced and released from the adrenal glands, because that's what is affected in congenital adrenal hyperplasia. I wanted to also point out that circulating steroid hormones are bound to specific transport proteins in the plasma, and that they remain in circulation longer than secreted peptide hormones. Those hormones that are protein-based do not remain in circulation for very long, but the steroid hormones do. And so therefore they can exert their effect far longer than the others that are not steroid. The adrenal glands lie along the superior border of each kidney. They're subdivided into the outer portion, which is called the adrenal cortex, and the inner portion, which is called the adrenal medulla. Now, in the adrenal cortex, we find that it stores lipids, especially cholesterol and fatty acids, and it manufactures steroid hormones, which are referred to as corticosteroids. The inner portion, which we're not going to be concerned with the condition of congenital adrenal hyperplasia, actually is controlled by the sympathetic division of the autonomic nervous system and produces epinephrine and norepinephrine. This slide shows the position of the adrenal glands like little caps on top of the kidneys. This is showing you the adrenal gland in section so that you can see the outer capsule, which surrounds the gland, and then you can see the cortex with the outer portion and the medulla, the inner portion. The adrenal cortex is subdivided into three regions: the zona glomerulosa, the zona fasciculata, and the zona reticularis. Please go to this YouTube video, and there is a brief summary of the different areas of the adrenal cortex and the adrenal medulla. The zona glomerulosa produces a group of hormones called mineralocorticoids, and this region is found in the outer portion of the adrenal cortex. The most abundant of all of the mineralocorticoids is aldosterone, and it stimulates the conservation of sodium ions and the elimination of potassium ions, and it causes retention of sodium ions by the kidneys, sweat glands, salivary glands, and pancreas, thereby preventing sodium loss in the urine, sweat, saliva, and digestive secretions. The middle region, which is called the zona fasciculata, produces glucocorticoids. For example, cortisol, which is hydrocortisone, with corticosterone, and the liver converts the cortisol to cortisone. The secretion is regulated by negative feedback, and it has an inhibitory effect on the production of corticotropin-releasing hormone, which is in the hypothalamus, and ACTH, which is produced in the anterior pituitary or the adenohypophysis. So if you want to review this, you can go back to the anterior pituitary secretion of the ACTH, and the hypothalamus secretion of the corticotropin-releasing hormone, CRH. The function of the glucocorticoids are to accelerate glucose synthesis and glycogen formation. They show anti-inflammatory effects, and in doing so, they inhibit the activities of white blood cells and other components of the immune system. And therefore, with long-term use and high secretion of glucocorticoids, it can have an effect of suppressing the immune system over time. The zona reticularis is a network of endocrine cells, and it forms a narrow band bordering each adrenal medulla. It produces the androgens under the stimulation by ACTH. Adrenal androgens stimulate the development of pubic hair in boys and girls before puberty, and the adrenal androgens are not important in adult men, but in adult women, they promote muscle mass and blood cell formation and support sex drive. This last slide is showing you the regions and zones where the different adrenal hormones are found, and you can see the histological section next to it. And then you can see the hormones produced in those areas, their primary targets, the hormonal effects, and the regulatory control. Congenital adrenal hyperplasia affects the production of one or more of the three steroid hormones: cortisol, which, remember, regulates your body's response to illness or stress; aldosterone, which regulates sodium and potassium levels; or androgens, such as testosterone, which is a sex hormone. In many cases, congenital adrenal hyperplasia results in lack of cortisol and overproduction of androgens. The milder and more common form of CAH is called non-classic. The classic form, which is more severe, can be detected in newborn screening programs. Some forms of CAH can cause problems with normal growth and development in children and even be life-threatening. Approximately two-thirds of individuals with classic CAH are classified as having the salt-losing form, while one-third have the simple virilizing form. In both forms, affected females have genital ambiguity. A child with the classic CAH may experience a lack in the production of cortisol in both the salt-losing and simple virilizing forms. Most of the problems caused by the classic CAH are related to the lack of cortisol, which plays an important role in regulating your blood pressure, maintaining blood sugar and energy levels, and protecting your body against stress. A lack in the production of aldosterone in the salt-losing form can lead to low blood pressure, a lower sodium level, and a higher potassium level. Sodium and potassium normally work together to help maintain the right balance of fluids in your body. And excess production of the male sex hormones, androgens such as testosterone, and this can result in short height, early puberty, and in females, abnormal genital development while still in the uterus. In infants at birth, the signs and symptoms of classic CAH are in females an enlarged clitoris or genitals that look more male than female, referred to as ambiguous genitalia, and in males they have normal appearing genitals. Also, there's a significant illness related to the lack of cortisol, aldosterone, or both, which is referred to as an adrenal crisis, and this can be life-threatening. In children and adults, the signs and symptoms of classic CAH include very early appearance of pubic hair, rapid growth during childhood, but shorter than average final height. Remember, this is due to the fact that you have the excess of the androgens being secreted, and that is what is going to turn off the growth of the bones at the epiphyses. Now, non-classic CAH is milder than classic CAH, and often there are no symptoms at birth. The condition is not identified on routine infant blood screening and often only becomes evident in late childhood or early adulthood. Hormone deficiency may only involve cortisol levels. Although teenage and adult females may have normal appearing genitals at birth, later signs and symptoms can include irregular or absent menstrual periods, masculine characteristics such as facial hair, excessive body hair, and a deepening voice, severe acne, And in both females and males, the signs and symptoms of non-classic CAH may also include early appearance of pubic hair and rapid growth during childhood, but shorter than average final height. Classic CAH is usually detected at birth through required newborn screening or when female babies show ambiguous genitalia. It can also be identified when male or female infants show signs of severe illness due to low levels of cortisol, aldosterone, or both. In non-classic CAH, you may notice signs and symptoms of early puberty in a child. In this case, when this is found um, and you have concerns, 95% of the cases, the enzyme lacking in congenital adrenal hyperplasia is 21 hydroxylase. CAH may sometimes be called 21 hydroxylase deficiency. There are other much rarer enzyme deficiency that also cause CAH, and CAH is an autosomal recessive disease. Factors that increase the risk of having congenital adrenal hyperplasia include parents who both have CAH or are both carriers of the genetic defect for the disorder. It is autosomal recessive. Members of certain ethnic groups, including Ashkenazi Jews, Canadian Mennonites, and Yupik Inuits. The complications of CAH are dependent upon the type of congenital adrenal hyperplasia and its severity. People with the classic CAH are at risk of experiencing adrenal crises. This is caused by severely low levels of cortisol in the blood, and this results in diarrhea, vomiting, dehydration, low blood sugar levels, and shock. It is life-threatening, it is a medical emergency, and it requires immediate treatment. The impaired production of aldosterone can also occur, and this leads to dehydration with low sodium and high potassium levels. These individuals are referred to as salt losers, and an adrenal crisis does not occur in the non-classic form of CAH. However, in classic and non-classic CAH, males and females may eventually experience fertility problems. For the diagnosis of CAH, prenatal testing can be done to diagnose the CAH in fetuses. This can occur because you have siblings that have the disease or other family members are known to carry a specific gene defect. Amniocentesis or chorionic villus sampling may be performed. All newborns in the United States are screened for classic CAH caused by genetic 21 hydroxylase deficiency during the first few days of life. This test does not identify non-classic CAH. The diagnosis of CAH includes a physical exam, blood and urine tests, and gene testing in older children and young adults. It may be needed to diagnose the CAH. And then there's also testing to determine a child's sex can be performed. In female infants who have severe ambiguous genitalia, chromosome analysis can be done to find out if the child is a boy or a girl. Also, pelvic ultrasound can be used to identify the presence of female reproductive structures such as the uterus and ovaries. A child with CAH may be looked at and treated by a team, which may consist of pediatric endocrinologists, urologists, psychologists, and geneticists as needed. Treatment will depend on the type of CAH and the severity of the symptoms and is aimed at reducing excess androgen production and replacing deficient hormones. With non-classic CAH, individuals may not require treatment or may need only small doses of corticosteroids. The medications may include corticosteroids to replace cortisol. This is the main treatment, as stated earlier. Mineral corticoids to replace aldosterone to help retain salt and get rid of the excess potassium, which could cause damage to the heart. And salt supplements to help retain salt. There is a treatment that can be done to a fetus. It's a synthetic corticosteroid that crosses the placenta to the infant, can be taken by the mother during pregnancy. This may reduce the secretion of male hormones, allowing the female genitals to develop normally. This treatment is still considered experimental. There's no clear evidence yet about the long-term safety of this drug. Because of the side effects and how the treatment might affect brain development, this remains a controversial treatment. Please view the videos that were put up there on CAH.